بسم الله الرحمن الرحيم. شكرا دكتور هيثم على التقدمة، شكرا أوي. النهاردة إن شاء الله هنتكلم عن a disease that has been quite prevalent among the world, and in Egypt in particular it has a high prevalence. الحقيقة يعني زي ما قلت قبل كده يمكن في محاضرة سابقة، كان في الأستاذ الدكتور أحمد عبد العزيز إسماعيل أستاذ الباطنة في القصر العيني من حوالي 30 سنة أو 40 سنة، كان بيستخدم السيروكسين كتريتمنت للأوبيزيتي. فهو طبعا كان اجتهاد شخصي، لا كانش لا ريكومنديشن ولا كان جايد لاين، انما ده كان يفتح الباب قدامنا عشان نقول الريليشن ما بين الثيرويد وما بين الفاتي تيشو. Agenda general overview about MAFLD, mutual relationship between MAFLD and thyroid dysfunction, and we will discuss some data from our research. This figure presents a definition for MAFLD، والحقيقة ظهر بعد كده MAFLD، لكن هو الكرايتيريا بتاع الدياجنوزز it is the same: fatty liver أو steatosis induced in patients with body mass index above 25 or body mass index less than 25 or patients associated with diabetes. In those lean patients whose body mass index أقل من 25 بيبقى في كرايتيريا عشان نقدر نقول إن دول ممكن يبقى عندهم مافل: الويست سيركمفيرنس والبلاد بريشر والبلازما ترايجليسرايدز، الهاي دنس لايبوبروتين كوليسترول والبري دايابيتس، ولو الفاستنج بلاد جلوكوز 100 إلى 125، البوست برانديال 150 ل 199، أو الهوما انسول ريزيستنس أكتر من 2.5، أو السي ار بي أكتر من 2 ملي جرام. ده for definition of patients who are liable to develop MAFLD. Diagnosis of hepatic steatosis is liver fat accumulation more than 5% of hepatocytes according to liver biopsy، أو أكثر من 5.6% as diagnosed radiologically. السلايد ده بيوضح الهيستولوجيكال features of MAFLD. تبدأ بالsteatosis with hepatic ballooning and then lobular inflammation which progress to liver fibrosis. Prevalence among world is about 20%. In Egypt it reaches about 47%, and of these 47.5%, 56% develop liver fibrosis. The pathogenesis of MAFLD is not completely known, but the multiple hit hypothesis considers several insults acting together on a genetically predisposed subjects. This figure presents the pathogenesis of MAFLD. هنا في الكولم ده بيوضح الفات accumulation is the gold standard pathogenic mechanism which is associated with necrotic inflammatory state on a background of genetic and epigenetic features. The metabolic syndrome with obesity and with diabetes causes lipolysis and de novo lipogenesis, which releases free fatty acids The free fatty acids leads to accumulation of triglycerides in hepatocytes, which induce steatosis. This steatosis, together with reactive oxygen species and pre-inflammatory cytokines and apoptosis, induce steatohepatitis. Steatohepatitis will progress to fibrosis and may be HCC. These are the stages of MAFLD, or which end in liver cirrhosis. Now, we may discuss thyroid hormone receptors. Thyroid hormone receptors alpha isoforms are expressed but mainly found in cardiovascular system, white adipose tissue, and in bone structure. Thyroid hormone receptors beta is divided into beta 1 and beta 2. Beta 1 receptors are present in brain, liver, and kidney, while beta 2 receptors are present in hypothalamus, retina, and pituitary. There are two types of hypothyroidism: subclinical hypothyroidism, where the current guideline بتقول إن above 4 TSH يبقى above 4 to 4.5. الأوفرت hypothyroidism طبعا بيكون TSH عالي مع اللو T3 and T4. كيم إيتال جمع عيانين biopsy proven MAFLD وstudied the entity of thyroid status في العيانين دول، وقسمهم. قال إن في مجموعة اللي هي has strict normal thyroid TSH يكون فيها 0.4 to 2.5. low normal thyroid TSH بيكون 2.5 to 4.5, and subclinical hypothyroidism TSH يكون above 4.5. طبعا المجموعة كان فيها السبكلينيكال hypothyroidism مجموعة هنشوف بعد كده حوالي 8% بس. Hypothyroidism induced MAFLD was acknowledged recently as a distinct disease entity. Hypothyroidism may probably be the best example of MAFLD secondary to endocrine disease. Prevalence of hypothyroidism in MAFLD. Some studies report that the prevalence of hypothyroidism is from 15.2 to 36.3% among patients with MAFLD, indicating that hypothyroidism is a common concomitant disease of MAFLD. Hypothyroidism-induced MAFLD, there is a linear association between TSH and increased risk of MAFLD، وده واضح في الفيجر الواضح قدامنا. Pathogenesis of hypothyroidism-induced MAFLD. Possible events. A recent large prospective cohort study, the Rotterdam study, showed that in the general population, even subclinical hypothyroidism is associated with increased risk of developing MAFLD and fibrosis. Hypothyroidism is a first mechanism is that hypothyroidism is associated with dyslipidemia and higher body mass index, which are in turn bound to increased MAFLD risk. Second mechanism, elevated serum TSH causes liver triglyceride accumulation via strep upregulation, subsequently causing steatosis. Third mechanism, TSH also induces intrahepatic lipolysis through lipophagy, which involves the sequestration and degradation of lipid droplets within hepatic lysosomes, eventually resulting in decreased triglyceride clearance and increased hepatic accumulation of triglycerides. The fourth mechanism is that hypothyroidism-related insulin resistance may induce lipogenesis, thus promoting storage of free fatty acids in the liver. وده هيبقى واضح حقيقة في الاستادي اللي عملناها إنه في correlation ما بين positive correlation ما بين TSH, rise of TSH and HOMA insulin resistance. Hypothyroidism increases adipocytokines such as TNF alpha and leptin, at the same time decreases adiponectin, thereby contributing to hepatic inflammation and fibrosis. The sixth mechanism, TSH stimulates hepatic gluconeogenesis and causes hypercholesterolemia by decreasing HMG coenzyme A reductase phosphorylation, ultimately leading to development and progression of MAFLD. And this also this figure demonstrates the pathogenic mechanisms of hypothyroidism-induced MAFLD. Studies, there are multiple studies that demonstrate relation between hypothyroidism and MAFLD. One study demonstrates that MAFLD subjects have a lower concentration of thyroid hormones. Another study demonstrates that even the minor rise of TSH levels are linked to higher risk and the prevalence of metabolic syndrome. Another study demonstrates that TSH can hasten the onset and the progression of MAFLD or NASH. Another study demonstrates that a sufficient reduction of thyroid hormone levels is enough to lower the response of adipose tissue to adrenergic signaling, leading to reduced free fatty acid transport to the liver. Raised TSH levels were correlated with higher hepatic lipoprotein lipase activity. Now we come to our research. The rule displayed by some genes, serum levels of cytokeratin 18, and some cytokines as non-invasive predictor biomarkers for the metabolic associated fatty liver disease by Mahmoud Khattab, Yusuf Ismail, Lamia Hamdi, Ilham Ahmad, and Umniya Ahmad. We have grouped 100 individuals, 45 were obese, body mass index more than 25, and 35 were lean patients with MAFLD, and 20 healthy subjects as control. This may be one of the fewest studies that included lean individuals with MAFLD. These are the exclusion criteria, and we come to results. TSH level was significantly higher among patients with MAFLD, whether obese or lean, compared as healthy control. While free T3 and free T4 was not significantly altered among patients against or versus healthy controls. Now, TSH and the degree of steatosis as diagnosed by MRI. TSH had a significant predictive value for diagnosis steatosis as detected by MRI. واضح من التيبل دي انه TSH correlates significantly with the degree of steatosis. يعني في steatosis grade 1
2.6 في جريد 2 3.2 في جريد 3 4.7. So it correlates positively with the degree of steatosis. However, TSH was not correlated with the degree of liver fibrosis. Correlation between TSH and MRI and shear wave. طبعا زي ما قلنا برضو TSH correlates with the MRI diagnosed steatosis but not with the shear wave diagnosed fibrosis. Levels of TSH and MAFLD according to Kim et al. زي ما قلنا السبكلينيكال هايبوثايروديزم حوالي 8% واللو نورمال 57% 37%. الستريكت نورمال كانوا 55%. When we done regression analysis for variables affecting grades of steatosis as detected by MRI كان الويست circumference والويست hip ratio والTSH level والfasting insulin correlating positively with the degree of or grade of steatosis. Insulin resistance and MAFLD also HOMA insulin resistance correlates with the degree of steatosis. Now, correlation between HOMA insulin resistance and the steatosis. Also, there is a positive correlation between HOMA insulin resistance and steatosis. Severe steatosis, the HOMA insulin resistance reached 14. Relation between TSH and the HOMA insulin resistance, there is a linear relationship between HOMA insulin resistance and TSH. Now, when multiple stepwise discriminant functional analysis of laboratory data were was done, there was a significant, among variables, significant in univariate analysis for the presence of moderate to severe steatosis. We detected that TSH was a discriminant factor for diagnosis of steatosis, and a discriminant score was obtained ودي المعادلة بتاع discriminant score for diagnosis of steatosis. The sensitivity data of this score is that sensitivity of 97%, specificity 100%, and area under the curve about 95%. Now therapeutic implications. يمكن هنيجي على طول على عشان بس التايم. Replacement therapy with levothyroxine or replacement therapy with thyromimetic drugs. We mean by thyromimetic drugs that are agonists to thyroid hormone receptors, in particular thyroid hormone receptor beta 1. هاريسون إيتال في 2019 randomized patient with biopsy proven NASH to resmetirom versus placebo, and resmetirom treated patients was found to have a significant relative reduction of liver fat compared to placebo at week 12 and at week 36. And this figure demonstrates the data obtained by Harrison et al. Currently, resmetirom is the only FDA-approved drug for treatment of MAFLD with the brand name Resdifra. Take-home message: the progressive rise of TSH as diagnostic marker for hypothyroidism is proportionally correlated with insulin resistance. Both variables are correlating with occurrence and grades of liver steatosis. Thyromimetics may open the way for safe and effective modality for filling the gap in treatment of a coming pandemic, that is the MAFLD pandemic. This presentation is shared with Dr. Umniya Ahmed, lecturer of Internal Medicine Department, Minya University, and thank you.